Anyone can calculate a 100% admission rate if you want. Only count the referrals that started care. You know?
Well, that's manufacturing your success. You're essentially just like removing the inconvenient pieces to just get to the prettier picture.
Yeah. Oh, that one? No, Dr. Johnson never sends the right referral form. Well, shouldn't the marketing team know? Shouldn't we go educate, have an in-service? Sounds like a marketing opportunity to me. Maybe we can help provide better service. Maybe they can tell us that our fax number doesn't work or that 1,000 other things are there.
Hi, everyone. My name is Mariam Treystman from the Home Health Consultant, and today we have the pleasure of having Austin Degenhardt, Managing Partner of HHA Pros Consulting. Thank you so much for joining us.
Well, thanks so much for having me on.
With your system, from what I understood, or correct me if I'm wrong, you did the audit on the spreadsheet, you made you broke it down into stages. And then what happened once you guys kind of went through that process?
So basically, we built a full technical layer to facilitate the process. For the first project that we did, originally, I wanted a CRM built for home health. And right now, there's only really one player in the game, Trella, which used to be Playmaker. But that's basically the only CRM that is built for home health. And I found some challenges with that because the referral doesn't go to the CRM, it goes to the EMR, and then the EMR tells the salesperson that the referral came in. It's text, so it happens fast, but that means you have to manage your referrals in the EMR, and in an EMR, it's binary. It's an admission, it's a non-admit, or it's pending. So, and that's where, even if you're not using a spreadsheet, if you're using your EMR to manage referrals, I think it's almost worse than a spreadsheet because then you have so many non-admit or pending referrals in an EMR, and there's no data, there's no information coming from that. Like, it's yes or no, or maybe, there's no information. So what we ended up doing was build what I kind of call a CRM that for the frontline community liaisons is what we called our marketers. For the frontline community liaisons, it was a CRM. It had all of your accounts, phone numbers, cell phones, all the information of your territory accounts. And then it also had reports within there for all of your accounts to see when was the last time they sent a referral, what's their Medicare percentage, all the important information that you want to understand for your market. But then what most CRMs don't do is intake is not on the same system as sales. So let's use the missing information example, right? Okay, I have Dr. Johnson. He's a great referral source. He just sent over a referral. We're missing a signature on page 3. I have Dr. Johnson's, I have Dr. Johnson's cell phone number, or I have his MA's cell phone. I can always get a hold of Julie. She's lovely, right? I don't know the referral came in yet, and it's pending, so I don't see it's a thing. So my intake team, who's helping me out because they know I'm in the field, they call Dr. Johnson's office, but they don't have the number that I have. To Julie, my lovely MA, who gives me the quick answers, I could just text Julie and let her know we missed a signature on page 4. So they call, they leave a voicemail. Nothing happens. They're doing their job. I think they're the second busiest people in home health is the intake team in busy markets. So they lose track of that. They're waiting for a call back from Dr. Johnson. The next day, I go into Dr. Johnson's office. I didn't know that I got a referral, much less that I needed to probably bring the referral for him to sign because I'm there in person. He never heard from me, so now it looks like my company, the left hand doesn't know what the right hand's doing.
And I mean, it looks like that because it's true.
It is so true, and to me, I feel like that, from a sales perspective, that was the biggest thing that damaged our reputation. And that's what I really wanted to fix from a purely sales side, was just, I want to look prepared and professional when I walk into an office especially once you get up to a big hospital and you're talking with directors of case management. I want all those case managers to say, when we send a referral to Austin at his company, we get an immediate response. We know if anything's missing. He follows up when the patient has started care. He always lets us know. I want to provide that next level customer service because, as you said, home health is a commodity type service. There's only so many ways to differentiate yourself in any territory, and customer service is the lowest hanging fruit. It's right there for you, but you got to be organized. Otherwise, the only other way to do it is what I've seen, and it's heroes. There's a hero marketer, there's a hero intake person, the DON is a hero, and everyone comes in and they save the day like 4 times a day. And the DON's there from 7 a.m. to 7 p.m., and the intake person is there from 7 to 10, and the marketers, we're more limited by the amount of time because when doctors' offices are open, but we're doing weekend visits to our case managers, and everyone's a hero. And then after about 2-3, everyone has their own burnout timeline, but I found the burnout to be massive.
Mm-hmm. The problem with having to have a bunch of heroes with this kind of situation is that you end up wasting their energy on disorganization, miscommunication, things like this. And so their ultimate, like the thing that they're there to do doesn't get the sharpest version of themselves because they're just like trying to fill in gaps and like, close holes and things like that.
Yeah. And for me, where I want my intake team spending time is on that patient phone call.
Mm-hmm.
I don't want them to have 25 tabs up with 1,000 things they're doing. I want them to be able to call and say, "Hi, Mrs. Johnson. This is Stephanie calling from Health Now. The reason for the call, your doctor at the hospital, first ask how they are. Mention the doctor, mention the case manager, mention their nurse, build some credibility." So we ended up writing scripts for the intake team as well. Once we freed up their time a little bit and got them more organized, then we help them to focus on customer service so that when they called a patient, it wasn't, "Hey, your doctor said that we need to come start home health, go through the qualifications, is this you? Is this your insurance? Da da da. All right, how's tomorrow at 2?" That works for probably 50% of patients, maybe 60 or so, who knows the exact numbers. But for those patients who just went through a traumatic experience, who aren't quite all as cognitively there in the moment, for patient families who are traveling, they're at their parents' house, they're not at their job, they're super stressed. You really want to come out with a real conversational approach, but you need to demonstrate that you're legitimate, that you come from where they were referred from, especially at the hospital level. If someone got out of UCSF, which is one of the best hospitals in the country, we have their doctor, right? We have their PCP information. We have their doctor who saw them. If it was a surgery, we have their surgeon. We have all those names on that referral form. We should be using those names. Hey, yeah. So that was something we found to be really helpful as well. But you can't have them focus on that if all their time is spent on uncovering where something is and all this administrative busy work.
Yeah, I feel like this is home health admissions is like Inspector Gadget, you're just like trying to piece this mystery together and whatever. And all of this is before you ever make contact with the patient. There's just so many like steps and components. But you said something interesting, and I had a little light bulb. I'm sure this is day one stuff for you, but you can't track. The reason we use spreadsheets for this kind of stuff is because you can't track this in EMRs. First of all, there's no reliable way in EMRs. Secondly, to enter a patient into an EMR, you need to know so much information about them that you don't always have at this intro level. Because when you're first getting a referral, you're not necessarily having their entire medical history. You might get this later once you've accepted it and, kind of like a few stages later. So sometimes it's really just a name, a phone number, an address, like a couple of details. It's not this extensive information that you need to put the required fields in the EMR.
Yeah, we're creating a chart for a patient we might see sometime ever. It's that burden alone is so heavy. Yeah, where I see how people ended up at a spreadsheet. Until that start of care call has been made, that's when you create a chart,
Right.
right? But there's so much that happens before that. But yeah, like you hit on the EMR, they're not equipped for it. They're medical systems.
You said another thing earlier, which was really cool and interesting, and that's that all of the indicators might be that things are good, and you're not noticing all these little details coming out of, just missing this patient or I don't want to say forgetting, but you know what I mean? Like things just slipping through the cracks for like this coordination problem or that.
What that really brings up to me is the issue of accountability. And it's one of the things that I've found in working with clients that gets really challenging because in home health, there's two cultures in every company. There's the clinical culture, which is majority of the culture, as it should be.
As it should be.
But then there's also the business element. And so generally the clinical culture is the primary culture, but oftentimes administrators or at larger companies, VPs, the operational side, a lot of times there's some conflicting things there. And so for me, the first project I did, when I recommended, hey, we should have a CRM system for a loose term for the intake team, there was massive resistance on that side. And then, so I asked the intake team, I'm like, okay, what do we think our admission percentage is? Let's go calculate it. That's how we got those 75% numbers. But we weren't counting referrals that never made it to a certain stage. If it was forgotten, we didn't, oh no, that the doctor never called us back.
Yeah.
Well, to me, that's on us, not on the doctor, right? We can't say, oh, they didn't send a complete referral, so we don't really like working with it.
So it doesn't count as in the total that we're calculating, yeah.
Yeah. Anyone can calculate a 100% admission rate if you want. Only count the referrals that started care.
Well, that's manufacturing your success. You're essentially just like removing the inconvenient pieces to just get to the prettier picture.
Yeah. Oh, that one? No, Dr. Johnson never sends the right referral form. Well, shouldn't the marketing team know? Shouldn't we go educate, have an in-service? Sounds like a marketing opportunity to me. Maybe we can help provide better service. Maybe they can tell us that our fax number doesn't work or that 1,000 other things are there. So.
Right. Well,
yeah.
And there's a big emphasis on performance improvement, but you kind of think about it from the start of care. You're not really looking at it in this portion because until they're your patient, CMS wants us to do QAPI. So what is QAPI? Quality Assessment Performance Improvement. And they want us to focus on like things that affect patient safety, care quality, things like that. Well, it doesn't count if it's not your patient. So this whole system prior to admission is kind of arbitrary to the clinical culture. You know what I mean? Like they're not looking at that. And I think, of course, like CMS is correct in wanting to place this emphasis on safety, on all this stuff. I'm not saying anything, but because of all of this QAPI stuff that we have to do and constantly performance improve, any kind of performance improvement is always focused in that category. They're not really looking at other sections because healthcare companies are clinician first. You are essentially treating patients. That's the primary focus, as it should be, like we said. So we're not really like looking at the other business processes in this way that you would if this was not a healthcare first company and was just like a business, right? Like in a business, you're constantly looking at these kinds of indicators. You're looking at the marketing. You're looking at all of this. This is as important as everything else. But in healthcare, of course, number one priority is healthcare. Like this is where it starts. So I think it's really cool that you identified that, like even just found it.
Yeah. Well, and I think you really hit on it. The whole industry is essentially based around what CMS wants.
Well, because there's so much they want, understandably. But
absolutely, their budget is totally unmanageable, completely insane. They're always trying to cut it, but they can't do it. But we got to reduce fees. There's so many things they're trying to do because it's just healthcare in general is a very unmanageable situation because everyone needs it. That's a bigger topic for another time. But you're right. So the person that pays you is telling you this is what you need to do. Better do it. I'm right there with you. But that's to get quality scores. If you want to grow or even have something more manageable, this is one of the things that I talk with my clients about. If you're doing $10 million, you own your own home health agency, it's a single branch. What do you actually want as an owner? Do you want to get to 20 and get to 30 and get to 40 and open up 5 new branches and have this massive organization that you have to manage? Or would you like to spend some more time with your family, have an organization that gives you enough money to live, that provides a much needed service to the community, where you have a great reputation and everyone loves you? Would you rather do something like that and have something manageable? And if you put the right systems in place, you can have a really great business and not have to be there all the time and not have to have all these fires. Home health to me was firefighting. It was just constantly, this is the next problem, and an ADR is coming, and this is coming down the road, and surveys coming. And it was like, can we just take 1 second and like look ahead for just 2 minutes? Let's have a quick meeting. Let's look ahead. Let's plan for what we actually want to, what are we going to do to grow? Right. And it's like more visits, more marketers, more. I hear what you're saying, but I think there's some other ways that we could differentiate ourselves inside this community to really position ourselves strategically to get more patients. Or this is the other thing I found. Let's say you're in a market where it's more challenging to just hire more clinicians and just scale your clinical side. Well, one of the benefits of having accuracy and visibility in your referral pipeline is, instead of saying yes to patients and then realizing you can't actually take them and then going back to the referral source and say, hey, Sally, I'm so sorry, I forgot, our nurse is out on vacation. Instead of that, the more that happens, the more it dings your credibility and professionalism. You can actually know exactly where you're at, and you can start saying no to a perfect Medicare referral that would be perfect for you, because you are fully staffed and you know how efficient and effective you are. I believe if you could get to the point as an agency where you're at that kind of optimal size for a single branch, you could actually improve the healthcare in a system by those referrals that you get because you're the best. You can pick the agencies that you trust that are good and reliable, and you can send the business to them, because no community can live with only one home health agency. There can't be a monopoly in this industry for a great reason. People need choice. And so the more organized and efficient and effective you get, the better. Again, it comes back to customer service, but I would tell our referral sources, doctors, skilled nursing facility, discharge planners, I would tell them, hey, you know what? We're full right now. I don't want your patient to wait. Please send them to this other agency. Here's the phone number of the marketer that I know. They're great. They're going to get you on care. They have a great 2-day SOC rate. I think they're going to be great. And I didn't get less referrals for doing that. I got more. Some case managers wanted me to kind of do their job for them, and I would distribute referrals out. I've seen that kind of thing happen. So yeah, there's a lot of opportunity by having accurate visibility and just getting more clarity in your process of what's happening.
Well, the worst thing you can do for your reputation in home health marketing is take a referral and give it back to the referrer.
Yeah.
This is the literal worst thing you could do for your reputation, especially in these high volume markets. We're in Los Angeles, so there's a lot of small agencies here. And I'm wondering, I'm not sure how San Francisco, how that whole area works, like North Cal. In LA, you have a lot of really small agencies. There's a few big ones too, but you have a lot of like 20 to 50 patient census agencies like this. And so, and there's a lot of them. I actually don't hate it. I really like this size as well, just from a consulting aspect, because you have this boutique care. You know, the clinicians are, you can wake them up in the middle of the night. They have you ever seen Erin Brockovich, like, you know, the
Oh
movie where
yeah.
she was like, just name the person, the name, phone number, their families, their phone numbers, whatever. So this is kind of like the vibe in LA where like you can ask any DON about any patient, they'll just like know it off the top of their head, like because they don't have 2,000 patients that they're, you know, it's not a number on a page for them. It's
Mm.
not just some MR number. Like this is a little more personalized. So I think it's cool in that sense. But what happens in this kind of market is that if you take a referral and then give it back to the referrer, you will never ever get a call from that referrer ever again. Like because there's just so much competition that they can send it to you. That's it. You're crossed off the list. So that is the worst thing you could do in LA market. But I'm wondering how do you see like in San Francisco that whole market, like where is it larger agencies? Is that how it kind of works? Or um
Yeah. It's a really interesting market. San Francisco being so impacted the way it is, uh, really creates a kind of a unique aspect. So in San Francisco, there were two private players that were relatively large. One agency really had a good amount of market share in San Francisco, so much to the point where it was like, wow, what are they doing? That is so much better because we would look at the Trello data and we would see like 40% of referrals from one place going to one agency. And there was still a lot of, there were a lot of the other players. And there were a lot of startup agencies that were happening. So everyone was looking to grow and trying to get market share. And they worked at another agency before. And it was a lot of, there was a little incestuousness around it in that sense. But it was a pretty diverse group, I would say. There were some startups who were just getting into it. There were a couple of those boutique agencies. And I have to say, what you were saying with having that experience where it's a manageable census, 50, maybe 70, maybe up to 100 even for certain DONs. The DON at the company I was working at, when we were at 300, she still knew a lot about every patient, but she's one of the hardest working people I've ever met in my life. And she was super passionate. So I'm sure that doesn't occur every single place, but that's what I loved is when there was a problem, the CEO, the DON, they would both go in, they would do a visit to a patient's house, they would make heaven and earth move for their patient. Even as they started to get bigger, obviously that is not a scalable thing, but even as they got bigger, they did that. And I think that at that boutique level, just like you said, a patient isn't a number, they're a patient. And when you can keep that type of culture, when there's a problem at night, that nurse is flying up, going out. Like, I think in hospice, you see that a lot too. At the smaller hospices, it's just, I personally like that aspect as well. I think it's a really essential part of it because, at a company with the scale of a Medicis, right, where there's hundreds of branch locations and all that kind of stuff, I mean, at some point, it literally, patient names drop off and it's just numbers, It's so big, you can't do it. But at the branch level, it's what I like about home health is even if you want to grow, if you look at each branch as a community organization, I think you can maintain some of that culture in there of patients being humans, not numbers.
you know when I would interact with surveyors, by law, by design, they come from different areas, right? And so we get a lot of surveyors from Florida, and in Florida, they have a certificate of need system. I guess you can't open an agency just like that in Florida. You have to like extra steps. Same with extra steps. And so you have a lot of counties where it's just one home health and one hospice in the whole county. And so, and there's just no way to compete with them, because to open another agency, you have to show that there's no home health in the area that can service them. And I just always felt, I mean, I know we're like veering off of marketing a little bit, but like, I always felt that that can't be a great system. I mean, if you're taking care of like 1,000 patients or 2,000 patients in your one branch and you're the only option, I can't imagine that being ultimately super good for the patients. Like in LA, San Francisco too, it's not one company. Like maybe it's not 5,000 companies, but it's not one company. That choice, that competition is what creates the extra good service. Like you have to be on top of it. The agency where it's the one agency in the county, they can forget patients all day long and nothing's going to happen because there's nowhere else to go. So people will just wait for them for their care, regardless of time frames, regardless of whatever, until they remember whatever. I don't know. I just interesting.
That's what happens in any monopoly, is the customer ends up suffering. In traditional business, any company that has a monopoly, they control pricing completely, and their customer service expectation, if you're the only game in town, can go to zero because they don't have to do it another way. So that's really surprising in some counties. I get how math-wise they got there, that there's no need, but imagine being a case manager. You're giving someone a choice. That's like there's one doctor in town, I mean, oh, is he a gyno? Because I need a guy, I mean, that's really tough. And I definitely agree that it's not in the patient's best interest to have one option. I really believe that at least at a hospital in a fast discharge environment, you need minimum of 3 options to choose from. And 5, I think, is really a lot better because patients need choice and who's going to be, plus they're in their homes. So if you don't have a good experience with one of those agencies in your home, what do you do?
Right.
You have no other choice. Yeah.
Plus, like, in any company, you work there long enough, they're going to go through ups and downs. Good people will leave over time, right? Like things happen. People leave, people come in. Sometimes they're great, sometimes they're not great, and it takes some time to you kind of weed those people out and things like that. And so the quality can do this. So there needs to be choice so that you can, make up for it somewhere else.
Yeah,
But
absolutely.
anyways, that's a tangent. It's a whole thing.
I like that tangent.
And can you let people know how they can get in touch with you if they're interested in your services?
Yes. LinkedIn is kind of the best place for me now. The company is HHA Pros, like Home Health Agency Pros. And so on LinkedIn, that's the best spot. I'm not really big on other social media platforms. And then Austin at hhapros.com. If you have any questions, concerns, thoughts, anything that if you heard the podcast and wanted to talk more, learn more, or any of that kind of stuff, I'd welcome any kind of conversations like that.
Perfect. And we'll make sure that we link all your info so that people can easily get in touch with you. It's been a pleasure talking to you. And again, this is Austin Degenhardt from HHA Pros Consulting. And I'm Mariam Treystman from the Home Health Consultant. Thanks, guys.
Thanks so much, man.
Bye.